Hello, my dear friends. Let us discuss the part 2 of the first paper of the DNB December series. And you will realize, just like you saw in part 1, this paper mainly has basic sciences questions. We had some sterilization, microbiology question in the first half. Here also in the second half, it's very similar. A lot of questions are the kind of questions which you would get with your common sense. You may not have studied them, but with some application, you can get the answer. My aim mainly is to make you realize that these kind of questions you can easily answer with some structure. Okay. Don't just jot down random points as they come to your head. Either write a flow chart or make a simple table or point wise with proper headings. That will make your paper, stand out. And then even a few mistakes here and there, or if there are a couple of questions which you just could not understand, you will still get marks, right? So let me try to make your life easy. So this is actually very simple. Types and indications or applications of surgical drains. Now see how I've made this. I would have simply started off as enlisting the drains like Rumovac drain, JP drain, Penrose drain, tube drain, but that doesn't make any sense. What you need to do is to give it a structure, like you know how drains have to be classified. Either they will be open drains, closed suction drains, or closed passive, that is non-suction drains. Let that be the first. Second is, what do the drains do, or what is the principle of each? So you will write for open drain, it will drain by gravity or by capillary action. Closed drains, which are having suction, will drain with the help of an inherent suction. Non-suction will drain purely by gravity or by capillary or dependent drainage. That's why the drains have to be put at a certain level. You cannot put the drain higher than the level of the patient because then gravity and capillary effect will not be very good. Then give examples of each, like a Penrose drain or a corrugated tube drain, which we put in surgical wounds, even intra-abdominally. They are open drains. Closed suction drains, JP drain or Romovac drain, they have an inherent suction. Non-suction drains are your normal SPC catheter, pigtail drain, any tube drain, nasogastric, urinary catheter. They are all non-suction drains. And then there are applications, dirty wounds, abscess cavities, intra-abdominal fluid collections. These are the places where you will use open drains or closed suction drains. Non-suction drains again can be an abdominal drainage, urinary drainage, intestinal drainage. So you have enough examples. Don't just jot down point one after another. Make the answer look like this. And if you don't want to make a table, then go point wise. First, write about open drain, principle, examples, applications, closed drain, principle, examples, applications, and so on. Surely you can score full 5 marks if you write this much in a question like this. Then you can write a little bit about indication, which you can fit in this table itself. Or you can write it separately, like a drain is mainly going to remove accumulated fluid, like blood in a cavity, or urine if it's in the urinary leak, or a bilioma for a bile leak, or lymph in an ICD if there is a chylus duct injury. Or some people put drains prophylactically, like you can put it in surgical wounds and cavities to drain fluid before it gets formed or the moment it gets formed. Abscess cavities, you always put dependent drains. Post-operative problems as a precautionary drain, like after thyroidectomy or after GI anastomosis or for obliteration of dead space. So these are the indications which you can fit in this table itself. This is a repeat question. This has been asked 2-3 times before. So if you've seen my earlier videos, you'll get it. So don't think from where this question has come. This paper has this question and one more question on anesthesia. And both of them are from that very simple anesthesia topic of Bailey, anesthesia and critical care. Very simple topic. It's hardly a 10-page chapter from which we just need to know IMP things. We had daycare surgery, which is also on similar lines, and ERAS protocols. So they all follow the same perioperative pathway. So don't think this is just a pure anesthesia question. But yeah, earlier they have asked WHO step up approach. So this is actually WHO. It is also called as WHO analgesia ladder. So if they ask it in these different ways, you should know this is what they are asking. Okay, so they all mean the same thing. It is called step up approach or WHO analgesia ladder or step up approach to pain management in surgical patient or various modalities of analgesia in a surgical patient. It can come in different ways. Now you use your common sense. If you don't know the step up, as to what you do in practice. So in any surgical patient, step one will be non-opioid analgesics. These are usually going to be NSAIDs, and you can enlist them sometimes in neurological pains or neurogenic pains in a surgical patient. You can use adjuvants like antidepressants. So many times you will use amitriptyline, gabapentin, and muscle relaxants. Right? They are add-ons which may be used, but the front line here will be NSAIDs. You start with lower grade like paracetamol or combiflam, that is paracetamol, ibuprofen, and then you step up to diclofenac. So that's how you will start in the step one. If the pain does not get controlled with a non-opioid, then step two obviously will become opioid analgesia. So here you will use drugs which can be given orally, or they can be given subcutaneously or intravenously, right? Especially if the patient is in hospital. So this applies to not just post-op surgical pain, but even to oncosurgical pain or oncological pain. So here you start with weaker opioids like tramadol, codeine, and then you can step up to other morphine analogs like plain morphine or nalorphine, buprenorphine. These are the other morphine analogs which are used, and they come available in patches also. So they can be used either oral or as a transdermal patch, or if the patient is in a hospital, we give patient controlled analgesia where they have the monitor, where they have that button with which they can top up whenever they need. That's called patient control. So that becomes your step two. And of course, you will continue with the step one drugs. And then step three, for severe pain, you can step up the opioids. So now you can use morphine, fentanyl, oxycodone, and you will continue with non-opioids. And there are further steps. This is basically analgesia ladder, but there are other ways of giving analgesia, which is not necessarily via the oral or the transdermal or the IV route. The fourth step will be to give blocks, nerve blocks, but that is pure anesthesia way of giving it. That is not a surgical way. So of course you can give nerve blocks like, perioperatively in bariatric patient, we give transverse abdominis plane block or a tap block. Or if you are having a multiple rib fractures or thoracic surgery, you can give thoracic epidural. They are the other interventional ways of pain relief. Or if the person is having pain of a malignancy like a pancreatic cancer, you can give celiac plexus block. So these are the other nerve blocks. They don't technically come in the analgesia ladder, but they will come in the pain management protocols. This was one little tricky question. Like even when I was reading this question and trying to prepare the answer, it took me a little time because what they have asked is not, means at least in the not since 2020 have they asked this exact question. And what they are asking you is to talk about the extracorporeal knots and some illustrations. Now I will show you the illustrations, but I can understand they are a little tough to reproduce. So even if you can mention the different types of extracorporeal knots, you will still get some marks. But for that, first you need to know what an extracorporeal knot is. And one or two you would have seen in practice, right? Like when we do appendicectomy, we make that knot outside. And with the knot pusher, we push it in and then we put it on the appendix base. So those kind of knots, at least you would have seen. So with some imagination, you can generate their illustration, right? So that knot was called the Roder knot. Now, what does an extracorporeal knot mean? Today's day and age, they are sparingly used because most surgeons are comfortable suturing inside the abdomen itself. But those who are not, or scenarios where you don't have the opportunity to generate the knot inside, what you can do is you can make the knot outside the body. That's why it's extracorporeal. Then it is pushed through the ports with the help of a knot pusher and put wherever it is desired. In today's day and age, it is used in appendicular stump. Rarely you can use it on the cystic duct or for pedicle ligation. Honestly, these kind of knots in today's day and age are very sparingly used. So what are the types of knots you should know? At least you should know the names. The first two are the most important ones. First is called Roder knot. This one you can easily illustrate. Okay, this you can easily illustrate. This is Roder knot, where what I do, first I make a few loops around the thread. So there are two suture threads, the one which is going forward, the one which is coming back. So along the thread, I make some loops usually 3 loops, and then I make a knot at the end. So 1/2 hitch, 3 winds, and 1 locking. So you must have made it. No, first you make a 1/2 hitch, then you go around, 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 and then you make another knot, and then you push it. So it goes in these 3 steps. So that is your roder knot. And the other is the Melzer knot, which is a modification of the roder knot where you take more throws. At least these two you should be able to illustrate, right? Other knots, at least you should know the name. There is a Duncan loop used in Gynac, a Weston knot, Mishra knot, Tennessee slider. So these are the other ones that you should know. Obviously, understanding and reproducing these illustrations will be difficult, but definitely Rhoda. And if you add more curves on it, it will become modified Rhoda or the Melzer knot. These two, if you illustrate, still you will get at least 3 to 4 marks in this question.